Hello, everyone. Thank you for the invitation. It's a privilege to be part of the meeting in Sri Lanka. So today, my topic would be use of imaging and physiology in complex interventions. So intracoronary imaging and physiology, it's very vital to have these imaging and physiology modalities in the cath lab. Why? Because it can simplify PCI. We know we can make more complex anatomical subsets into more simplified ways to treat the most significant lesions, as well as we know it's a very optimal tool for even diagnosing the significant lesions as well as optimization. I think we have a lot of evidence now for PC optimization and identify treat complications and also to improve long-term outcomes. So let me start with the different subsets of lesions. In left main lesions, we know that physiology does have an important role. For isolated left main, it's quite easy to perform the FFR, which can be either the LAD or the circumflex. And if it is significant, more than 0.8, it gets non-significant. And also we should know the pitfalls. If you have multiple tandem lesions, we should be aware that we should use the other vessel, for example, the circumflex, to assess the FFR. And also it is unreliable when you have collaterals of other artery, for example, the right coronary CTO, which is also supplied by the left system, which usually indicates that the territory of supply is larger and it can be falsely positive. So looking at the significance of the left main, can also use imaging. And particularly in this area, IVUS has quite been shown to be very useful. For example, someone, particularly in Asians, if the MLA of the left main is more than 6 millimeters, it can be left with medical management. And if the MLA is less than 4.5, it is significant and is very well correlated with the FFR and needs revascularization. In a borderline IVUS MLA of 4.5 to 6, it is, of course, can consider using an FFR, which is very useful. And FFR is, if less than 0.8, it's considered significant. And showing an example, this is a patient who had come with a discomfort and shows LBBB on ECG. However, the CT angio shows some minimal disease in the left main and some lesions in the LAD. Our nuclear perfusion scan shows ischemic perfusion defects in the right coronary artery territory. So looking at that, also the CT showed a moderate lesion in the right coronary artery. So based on that, he was planned for a PCI to RCA. However, when the angiogram was done, you can see that there is, if you carefully look at it, though it doesn't appear to have any significant lesions in the left system, the left main appears to be slightly smaller compared to the LAD. So we have to make sure that we are not miss out any of the left coronary lesion, and also there is some damping of the catheter. So he was subjected to FFR, which showed a significant disease in the left main with an FFR of 0.77, both in the circumflex and the LAD. So which shows that the left main is significant, and the right coronary artery FFR of 0.82, which again shows it's not significant. And you can see that the IVUS also confirms that the minimal lumen area in the left main, you can see that eccentric lesion is 4.2 square millimeters. And as I mentioned, less than 4.5 is significant. And hence, this patient was planned for a PCI to left main. The other important area of imaging is for image optimization, particularly in left main, where one can look at any stent deformation, as well as to understand the malapposition and adequate expansion, and whether we have covered the stent age and covered the entire left main, and there is no geographical miss, as well as to look at the edges of the stent. So we have good criteria when you have at least more than 90% of the distal reference size as a minimal stent area. So also we know that there is a lot of evidence now to say that the post-PCI MLA, the IVUS, should be at least about 6 in the circumflex, 7 square millimeters in the LAD, and 10 square millimeters in the left main, which is the new criteria, particularly in large build patients. Though the earlier criteria of 5, 6, 7, 8 is not commonly used nowadays. So there also is an example where this is a patient who had come with a acute coronary syndrome, a young patient with LV dysfunction, critical triple vessel disease with left main and distal diffuse disease, and a CTO of the circumflex, multiple OM branches. So he had impella assisted PCI, with multiple stents to mid-LAD, distal LAD, OM, and also finally left main bifurcation stenting, which was done. And you can see the left main post PCI. And here we could see the area which you can see in the ostium of the LAD. It's 10.06, and the distal LAD is 3.4, and proximal mid LAD is 9.7 square millimeters. And in the ostial left main, we have an area of 19.96, and the mid left main, it is in the 14.89, which clearly shows we've achieved a very adequate MSAs, which gives very good long-term results. So HDIOS is again a very useful imaging modality to assess post-optimization after left main stenting. Now, moving to acute coronary syndromes, again in acute coronary syndrome, we know we should identify the culprit lesion correctly, and sometimes angiography may not show the correct culprit lesion, and hence imaging is very useful. Particularly the OCT helps to delineate the culprit lesion and hence guide therapy. Also identify spontaneous coronary dissection. Also, one should consider imaging when there is no evidence of significant coronary disease by angiography in order to characterize the aminoca. So let me show you an example. This is a young man with no risk factors, comes with anterior wall MI of 2 hours duration. And we can see here that the left main appears normal, circumflex is normal. The LAD has a thrombus in the proximal portion. You can see the thrombus, which is, there's no flow limitation. Flow is good, but the huge chunk of thrombus in the proximal LAD. So this patient was subjected to OCT. OCT is very helpful. You can see the distal vessel was normal. Now you can have the diseased vessel. You can see a fibrotic plaque, some amount of lipid-containing plaque. And now the vessel appears normal here with 3 layers. Again, you see atherosclerotic plaque with the fibrofatty plaque. And you can see this is a typical plaque erosion with thrombus protruding from the arterial wall to the lumen. So this is a typical of a plaque erosion causing acute coronary syndrome in a young male, where we don't see any lesion. So this patient was just treated pharmacologically with 2B3 glycoprotein 2B3 inhibitors and medication, and he did extremely well, and he did not receive a stent. So next, moving on to bifurcation lesion. Again, we know the importance of imaging in by complex bifurcations. It helps both IOS and OCT will be helpful. And OCT is particularly more useful in bifurcation lesions because we can assess not only the plaque amount distribution, and also it helps to identify the wire position, whether we are caused through the distal strut or the proximal strut. And we know that in a provisional stenting, distal crossing is more important. And the OCT really helps, 3D OCT really helps to understand where the wire is and achieve optimal wire crossing. Also in abdominal wire crossing, we can identify the wire goes beneath the stent. One can identify and do a proper wiring based on the OCT. And similarly, FFR does have a role in assessment of side branch. When we have a doubt, we don't have to unnecessarily put another stent in the side branch. There is also a lot of data now, particularly in the left main bifurcation stenting. One can look at the carina and look at the stent configuration, the ostium or the circumflex. This is a stent crossover stent from left main to LAD, and one can look at the circumflex ostium, which is covered by the stent struts. Whether it's a link-free type, which means there is no link in the ostia of the corner, the circumflex artery, or a link connecting type, where you have a link which is present. And also there is no jailing at all, then you don't have to do anything. So if it's a link-free type, it's quite easy to do a kissing balloon, and then you can make sure the struts are taken away. Whereas in a link connecting type, it's sometimes difficult to remove the link connection and may require an aggressive pot followed by aggressive kissing balloon, or sometimes even a push balloon technique to push the struts of the stent. So this is again very useful by OCT to identify the pattern of a strut in the ostium of the circumflex in a left main PCI. So similarly, also one can look at the risk of side branch occlusion. Like for example, this patient who has the longitudinal image, you can see a spiky carina, which means the carina is pointing towards the side branch, and this predisposes to side branch occlusion, as you can see in this angiography. The patient, after stenting across the side branch, has lost the side branch because the carina has shifted because of spiky carina. So all these can be identified based on OCT. Another important identification is to look at the calcified plaque or a calcific nodule opposite side branch. If you have a nodule opposite the side branch, when we do PCI, we may not yield to the lesion, and then the stent may not expand in the other direction and expand in the opposite direction. and hence cause a carina shift and occlusion of the side branch. And this, if we identify the calcified plaque by imaging, one can either use a debulking and make sure the calcified plaque is properly addressed before we stent, so that we can avoid a shift of the carina and loss of side branch. So this is an example where this is a patient where we can see that there is a heavy calcium and the LAD just opposite to the circumdiagonal ostium. You can see that there is heavy calcium, and once we debulk and then put a stent, the stent expands well, and there is no closure of the side branch, even though there is mild pinching, one trend closure. So it's important to understand and debulk the proximal main vessel before stenting the side branch. Let me show an example of how OCT is very useful in sizing. And this is LAD diagonal bifurcation. One has to look at the distal size based on the OCT. It looks like there is a gross disparity in the sizes of the proximal and the distal LAD after the diagonal. Diagonal appears to be a significant size, almost quite bigger than the distal LAD. Important that this bifurcation be treated properly with imaging. So we have done an stenting and kissing balloon, and we want to see the OCT where we can see the OCT. After predilatation, we can see the OCT, the sizes of the distal proximal LAD as well as the distal LAD, the plaque characteristics, and understand the carina and the length of the stent. Everything can be done by OCT, and followed by that we do a stenting, and then the kissing balloon and the pot and the kissing balloon, and finally you have this result with a good position of the stent, proximal and distal. There is mild pinching of the diagonal. Though the diagonal is very big, we can see that we do an FFR and see that the FFR is 0.89, which is clearly not significant, and unnecessary treatment of diagonal is avoided. And this is post stenting OCT, where you can see that you can see that the diagonal is patent, and you can see that there is some deformation opposite at the carina, which should be corrected with the pot in the proximal optimization, where you can make sure we have a final pot helps to achieve a good result in the bifurcation. And we can also see that the stent apposition is quite well. There is no edge dissection, both in the proximal and distal. And you can also see the stent footprints are much lower in the upper branch due to post-dilatation and the pot. So calcified lesions, again, we know imaging is critical. If you look at the lesion approach, if you have moderate calcium, again, imaging, and severe calcium, it's also imaging as a first option to understand the lesion and then treat appropriately. So there is several scores, and this is a calcium score based on OCT, which is very widely accepted. So if you have a calcium arc, which is more than 50-degree arc, or if you have which is more than 180, so that is 2 points, and the thickness of the calcium, again, which is very exclusive to OCT, cannot be seen in IVUS. Again, the calcium thickness is more than 0.5 millimeters, it's 1 point, and the lesion length more than 5 millimeters, 1 point. So based on this, if the patient has significant calcium, they will need atherectomy before stenting. And similarly, in IVUS, it's got a calcium score which is based on the calcium arc as well as the presence of calcific nodule and the presence of the vessel diameter, whether it is small or large. So based on that, if the calcium score is more than 1, then we should consider atherectomy. So this is a case example of an elderly man who has got a calcified lesion. You can see the heavy calcium in the proximal mid-LAD, as well as there is a significant lesion in the circumflex, as you can see, and the right coronary has got some minimal disease. So he was taken for PCI to the LAD. OCT catheter couldn't cross. That's the first option, but hence an NC balloon crosses, but there is a significant waste. So we tried to use an IVL. IVL balloon does not go through. So rotational atherectomy was done with a 1.5 millimeter burr, and then followed by that we do imaging. And if you look at the OCT of the rotational atherectomy, you can see the rota cuts made by the rota burr, which is clearly evident in the OCT. And the OCT also shows heavily thick calcium. You can see the circumferential calcium, which is heavy, and almost thickness is more than 1,000 microns here. You can see a heavy 360-degree heavy calcium. So it's quite a large segment of calcium, more than 20 millimeters, with a large calcium burden. So this is clearly a high calcium score. And this patient, as you can see in the still image, the dense calcium, which is quite circumferential, the score of more than 4. Then followed by rotablation, a shock wave lithotripsy was done with a 3 into 12 millimeter IVL balloon, which you can see the waist of the shock wave balloon disappears as the shock is being delivered. And this helps to treat the dense, deeper calcium compared to the proximal calcium, which is treated by rotablation. This post calcium and post IVL imaging, we can see that there are a lot of fractures caused by the IVL, which is even extending up to the deeper layers of calcium. So by using both the rotablation and IVL, we can see that the nice fractures which we have achieved using these two modalities, and this has really helped to fracture this calcium, which can very well be appreciated with OCT, also 3D OCT, and followed by stenting with a long stent in the LAD and OPN balloon. This is a final result. We can see the stent has expanded nicely with almost 100% expansion and with good edges, so which can be very well appreciated with OCT. We cannot have achieved this kind of a result without the OCT guidance and appropriate debulking with the rotatripsy. So this is the final angiographic result with a good apposition and a good result with the stenting. So now also imaging is extremely useful in cases of stent failure. This again is one of the very important class 2A indication, both in patients with stent thrombosis as well as in-stent restenosis. So one can look at the cause of restenosis and failure in this example, where we can look at whether there is a neointimal hyperplasia, or is there a neoatherosclerosis, or is there a underexpansion, which is again very, very important cause, a treatable cause of stent failure. Again, this can sometimes result in stent thrombosis. Again, to understand the mechanism of stent failure and then treat appropriately will help to avoid re-restenosis and good long-term results. So this is an example of a patient who had a 60-year-old man who had circumflex PCI with NSTEMI, and they had come with the stent thrombosis, and we could see that by imaging, we could see that stent was grossly malapposed, and there is a significant amount of thrombus which is formed around the stent, and you could see thrombus extending down, and it's the cause of stent thrombosis. Here we just did a plain balloon dilatation to adequately expand the stent, and making sure we have achieved a good apposition without any further need for additional stent. So it's important to understand the cause, the mechanical problem, and correct it. And if you identify a biological problem in in-stent restenosis, one can accordingly treat. This patient was treated, as you can see, with a good expansion. Now, the underexpansion again is one of the most important causes of in-stent restenosis. And as you can see, this is a patient who has come with the neointimal hyperplasia. So when the whole stent underexpansion should be assessed and appropriately expanded, so that this again is a very treatable cause for stent failure. If there are multiple stents, again we should know that it's important to understand to properly dilate it rather than putting additional layers of stent and giving a final good MLAs and good expansion of the stent. So now moving to multivessel disease, again imaging and physiology is extremely useful, such as in this example you have multiple lesions in all the three vessels. But if you think that the lesions are significant and based on angiography, sometimes we're completely wrong. As you can see here, the RCA lesion appears not to be significant, whereas the LAD lesion appears to be more significant. So appropriately, we can treat using physiology, and also in multiple complex lesions, like in serial lesions, one can identify by mapping physiologically, identify the lesion which is significant, treat only that lesion so that we can reduce the number of stents. For example, if you look at the fullback of using an FFR or an RFR or IFR, here you can see that in a diffuse disease, you will have a pattern of gradual slope of the curve, whereas here there will be a sudden step up which indicates a focal lesion which needs to be treated by a stent, whereas a diffuse lesion, there is no clear indication for a stent, and these patients do not improve with stenting. And if it is significant, we need to think of other modalities or use CABG. So in this example, we have a patient who has an elderly lady who has got multiple lesions in the LAD. You could see that the LAD ostium is calcified and diseased, so the left main appears normal. There is no landing zone in the left main, and you have a mid-LAD lesion, almost distal LAD lesion, So if we had to there's a circumflex osteal lesion, also the lesion in the OM and the proximal circumflex. So based on this angiography, the patient would need multiple stents in the circumflex OM, starting from the left main to LAD, mid LAD, and up to the distal LAD. So this patient is subjected to FFR. Otherwise, the stent length will be very long if you look at the LAD and the OM. We decided to do a FFR guidance, and we do FFR, the FFR to OM, and the circumflex is normal. There's RFR for both FFR and RFR were done. So RFR clearly shows which is the OM and the circumflex lesions are not significant. Now to the LAD lesion is very significant, RFR of 0.62. We know the cutoff value for RFR is 0.89, and this means that the entire LAD and the left main is significant. So how do we identify there are multiple lesions? Is the osteal LAD significant? The distal lesion, do RFR pullback, and RFR pullback is extremely useful here. You can see these lesions, lesion number 1, 2, 3, and the 4 is osteal lesion. Now, as we move from the RFR from distal to proximal in a pullback, we can see that the lesion is a step up. From the step up is highest in the lesion 1 and lesion 2, and there is a step up is small in lesion 4. So what we need to do is to take the pressure from the present RFR of 0.62 is a baseline, 0.62. We want to take it to next level, which is up to the lesion, where we can achieve an RFR of 0.95, which means the first lesion, lesion number 4, need not be treated. So if we address the distal, the proximal, distal, and the mid lesion, that is lesion number 1, 2, and 3, we can achieve an RFR of 0.95, which is more than enough, and avoid treating the osteal LAD lesion based on the RFR. So exactly based on this, we did treat with just one stent for mid and distal LAD, and we had a landing zone. We avoided the LAD and the left main, and the post PCI RFR was 0.98. So clearly, we are able to establish good flow and a good post PCI RFR with just one stent, leaving no stents to the left main LAD or the circumflex, which clearly simplified the PCI in this complex multiple lesions. Again, another important investigation is using prior registration with using both IOS and IFR. This is again, there's a lesion where you have a bifurcation lesion with a long lesion, the LAD proximal to the diagonal and distal to the diagonal. You can see there is a long lesion. One can identify which is significant, whether to treat the entire LAD or only the proximal LAD, and also using IOS co-registration as well as the IFR co-registration, one can identify exactly the site of the lesion and the significance of each part of the lesion. This IOS pullback, and we can also do an IFR, where you can see the IFR was 0.77 distally, which is quite significant. And if we decide to treat the entire segment of the vessel here, you can see these are the points where you have the highest drop in pressure. And if you're able to treat the entire vessel up to the distal LAD, we can estimate that IFR is 0.95, whereas we treat only the proximal lesion, we will not be able to achieve a good IFR. So based on that, we decided to put a long stent from the proximal to the distal LAD. And this is post PCI. We do a IOS pullback, and then we can also do an IFR, which shows a signal normal 0.95 IFR. So clearly, using a co-registration with simultaneous registration of IOS and IFR, one can identify and also predict the post-PCI FFR. Depending on that, we can stent that particular lesion. So post-PCI FFR is again an important imaging modality, which we can help us to know that the long-term results will be good. And it's optimal to achieve at least a post-PCI FFR of above 0.94. And based on that, one can decide to do adequate post-dilatation and even imaging to make sure we achieve a good optimization post-PCI. So coming to the next subset of patients with CTO, again, IOS is extremely useful here, particularly in if you have an osteal occlusion of LAD, for example, one can use IOS into the circumflex and guide wiring of the CTO of the osteal LAD with IOS. So it's also useful in reverse cart or even in antegrade dissection reentry when no injections can be given. And IOS can facilitate entry into the true lumen when we cross the CTO lesions. And particularly, IOS is also useful in PC optimization. and management of complications during PCI. This is one of our examples where you have a total occlusion CTO of the LAD, CTO of the RCA, where we get trying to open it with the antegrade approach, and we are not able to cross, and then we use an IVEST, and we find that we have gone through the false lumen. If you can see here, this is a true lumen proximal cap. We cross and gone into the false lumen. You can see the true lumen compressed here, and you can see the true lumen. This is the true lumen. And now, now what we do is we use a Gaia 2 wire, we remove in a fine cross, and we reintroduce a wire into the true lumen. And here we have crossed. This is a part where we cross from the false lumen to the true lumen, and then we go into the distal true lumen, and then we put and also identify the true reference diameter in the proximal segment, the distal segment, and the landing zone. Depending on that, the diameter and the length of the stent is selected based on the IOS, and we're able to, two stents were placed overlapping fascia, and this is the final result. And IOS really helped in this case to get into the true lumen. So finally, to summarize, imaging is very critically useful in cath lab, particularly in complex lesions, not only in diagnosis, but also in patients who have guidance and PCI optimization and all complex PCI, including left main calcified lesions, bifurcation PCI, long lesions, multiple lesions, as well as multi-vessel PCI, and in CTOs. It's also helpful in stent failure, both in stent thrombosis and ISR. It's useful in a diagnostic, particularly in left main, and also imaging is very useful to assess any ambiguous lesions or a borderline lesion, and it can help to reduce the syntax scores. Complex lesions can be made more simple. We know that the syntax score after using FR can be brought down by making it as a functional syntax score, thereby reducing the number of vessels to be treated. And in patients post-PCI, FFR is again very useful to understand that we have achieved a good result, as well as to give excellent long-term results. So with an increasing complexity of both anatomy as well as patient comorbidities, the role of imaging and physiology to guide PCI has become critically important to improve overall long-term outcomes, and will definitely continue to grow. Thank you for your patient listening.